Swayam Prabha. Digital India. Educated India.
Welcome to this first plenary session. I am Mr. Karimi from National University of Singapore, and it's my pleasure to welcome Dr. Vipin Gopal, who is going to give us a talk on AI transformation in the pharmaceutical industry. So, Dr. Gopal is an IIT Bombay alumnus, and he got his PhD from Carnegie Mellon University with Prof. Ignacio Grossman, and he is the Chief Data and Analytics Officer at Eli Lilly. I'm sure you have heard of Eli Lilly. So he's a veteran in the space of advanced data and analytics, and he has a significant track record of building high-performance data analytics functions. He's a thought leader, right, on the transformational power of
recording in progress.
Advanced data analytics for a broad range of topics in healthcare, and for that he was recognized as a 2018 top 100 innovator in data and analytics. He is also an authority in the best practices for how to best make digital AI and ML work, and as I was talking with him, he has worked on a variety of data handling and how do you make use of those data. So it will be very interesting. I know AI is everywhere now, but pharma industry is also sort of waking up to the reality and the power of data and measurements and control and continuous manufacturing and things like that. So it will be interesting to hear his perspective on how AI and ML and all the data are transforming the pharmaceutical industry.
Well, good morning, good afternoon, and good evening to everybody attending in the room and online. It is such a pleasure to be here. I was telling Professor Raj and Professor Karimi that the last time I was here was about 34, 35 years ago. For those of you who are familiar with the IIT system, after you pass the exams, you visit a certain campus to select what subject you want to study and what IIT campus you want to go to. And that was this campus for me 34 years ago. I did end up going to a different IIT, but the fact that this is the first IIT I visited remains close to my heart. I'm also excited to be here with the process systems engineering community. I grew up in that community, and as Professor Karimi mentioned, got my PhD at Carnegie Mellon in the process systems area. My career has evolved since then, but really glad to be here as part of the PSC Asia conference, really coming back to my roots in some sense. What I want to talk about today is the AI transformation in healthcare. And why do I want to talk about that? Having been in the healthcare space for close to more than a decade and a half, I do feel very strongly that a systems approach to solving problems in healthcare is a very important one. And which other community than this community, the process systems engineering community, is better equipped to really look at this from a systems perspective and solve for some very important questions in healthcare. So I do think there are lots of opportunities for the process systems engineering community. If you think about it, the human body is a system, the healthcare operations is a system, and really looking at this from a systems perspective has a lot to be, has a lot to offer to solve big problems in healthcare. So for those of you who are in healthcare, maybe this is a high-level overview, but for those of you who are not working in healthcare, hopefully this will give you an overview of the possibilities and the type of questions that can be solved, and the potential of systems thinking and AI to solve those questions. So, what are the high-level questions and challenges in healthcare? One of them is increasing healthcare costs. When you think about it, the global spend in healthcare is about $8.3 trillion, $8.3 trillion US dollars, and that is, if you consider about $80+ trillion as the global GDP. That is 10% of global GDP is spent in healthcare. Globally, per capita spend is slightly higher than $1,000. Per person, how much is spent. In the US, it is actually 10 times that, $10,000 per person per year is spent on healthcare. And the US healthcare cost annually is about $4 trillion, which is about 18% of the GDP. So in developed countries, the percent of healthcare spend as percent of the healthcare spend as a percent of GDP is higher. So that's where, as countries are making progress, you would expect to see the healthcare spend going up. So all of this spend is not necessarily resulting in great healthcare outcomes. The picture that you see here is a stunning story of how healthcare or people's health haven't necessarily improved over time with this amazing amount of spend. So this is a picture from the US, given that I've been in the US for a while, so some of the graphics that I show would be from the US. And again, you can think about this as a representative of what's going on around the world. So this is a picture of how obesity has evolved from the 1990s to 2010. So the light blue colors is every given state. If it's a light blue color, it means less than 10% of the people are obese. If it's a dark blue color, it's about 15 to 20%. And if it's a dark red color, it is greater than 20% or 30%. So what you're seeing here is over a period of 20 years, obesity rates have grown like crazy. And as all of us know, obesity is perhaps attributed to many other conditions like diabetes and so on and so forth. So while we are spending a whole lot on healthcare, health outcomes have actually in many senses gone bad. 78% of adults over age 55 have one or more chronic conditions, and one in every child that is born today will have diabetes sometime throughout their lifetime. So there are some serious problems to solve in healthcare. It's not just about the cost. It is about this. How do we keep people healthy? How do we make sure that we have better treatments for diseases, etc., etc.? How do we look at it from a systems perspective as a human body? If you're curing one condition, what are the other effects that could be there? And really thinking about it as a whole human health. And solving those questions is of paramount importance. And that's not easy. Healthcare, as we all know, is extremely a complex system. There was a study in the New England Journal of Medicine that talks about what determines somebody's health. And that is that pie chart on the left-hand side of the slide. If you look at it, healthcare only accounts for 10% of what determines human health. So healthcare and health are not directly health. For the causality is not 100%. So there are other aspects, including people's behaviors, how they live their daily lives, genetics, social environments, environmental factors, etc., determines somebody's health outcomes. So when you sort of look at that and look at bring a broader lens to how do we improve health, we have to be looking at all these factors and really think about how you influence all these factors to result in better health. the picture in the middle, The Secrets of Long Life, is actually based on an article from National Geographic, where they looked at where in the world people live the longest. They really asked this question, and they determined that 3 places when the study was done was Okinawa, Japan, Loma Linda in California, and Sardinia in Italy. And those were the 3 places where people live the longest. And they asked the question, why would people live in these areas, live the longest? What factors could be contributing to that? And that is partially explained by the pie chart on the left, because it's not because those 3 places have best healthcare. It's not because they have best medicines available. It is a lot more in terms of what determines a person's health. So that is the big picture with respect to healthcare, and what are the questions, and why it is important from a societal perspective to be looking at these questions to really improve people's health, because there are lots of challenges that are there today. So many people would ask, okay, these are exciting questions to answer. Why are we not doing it yet? And many industries, as you all know, have been transformed with data analytics, digital, and AI technologies. And this is an example. This is an example of the transportation industry, as you all very well know. When you're trying to pay down a taxi, what's the pass, and the industry is completely changed. The car is actually coming to you as the customer instead of the customer going to the car. And the important aspect of that change is the customer centricity. The patient is at the center. In this case, the person who's riding the car is at the center. And how do you make it happen where the patient is at the center in the healthcare system? And this is again from a different industry. And you can think about these notions happening in many other industries. And I love this quote from Andrew Ng. Andrew is again one of the preeminent thinkers in AI. Andrew said it's difficult to think about a major industry that AI will not transform. So put it differently, Andrew was saying that every industry will be transformed in some sense or the other with AI. And my addendum to that quote is that pharma, life sciences, and healthcare are no exception. Because there's still some skepticism because of the complexity of healthcare, the healthcare system, the complexity of how healthcare systems operate, the inertia that healthcare has, doing things the same way. Whether AI can make a difference in healthcare. I'm personally, I may be biased, given that I'm from the space. I strongly believe that pharma, life sciences, and healthcare broadly will be fundamentally transformed over time. It's not a question of if, it's mostly a question of when. So let's take a parallels on, again, going back to the transportation space. And when it comes to you sitting in the car and driving, AI is already in that experience today. Sometimes we may not think about it. Maps and directions. Whether using Google Maps or Waze or other map systems, lane departure warnings, and so on and so forth. And the ultimate goal, when you think about this in some sense, is the picture on the left-hand side, right? You get into a vehicle, the vehicle drives by itself. You may be reading a book or watching a movie while going from point A to point B. And that is the notion of self-driving cars. In that space, that is the holy grail, right? And how is that thinking compared to what we want to achieve in healthcare? So let's think about this. And this picture is courtesy of Eric Topol. So when you think about the driving experience, there are 6 stages or 5 stages of formation. When you call stage 0, which when you see here, there's no automation at all. The old days of driving where the driver was doing everything, there's no necessarily any assistance. And stage 1 is the driver assistance stage, where the system is providing some support. I think most cars are here, but the driver is essentially in large amounts in control. And the second stage is partial automation. And when you think about that, there are some things like cruise control, lane keeping, etc., where in some cases the car is driving by itself. Driver is not necessarily doing anything. But again, it's partial automation. So in stages 0 to 2, you can think about this as the human driver is the one primarily monitoring the environment, and the system is providing some support. When you get to stage 3, 4, and 5, the system is monitoring the environment, and the driver is providing some support. So stage 3 is the system is monitoring, and human is there for a necessarily what you call a backup. Stage 4, it's a backup, but in very limited way. And stage 5 is full automation, where the car is driving by itself and the human has no role. So let's ask this question, okay, in self-driving cars, that is the eventual goal. In healthcare, it is debatable whether stage 5 is where you want to get to, where the AI systems is completely providing the care and human has no role. You may want to ask yourself if that's where you want it to be. Or if you go to the step slightly before that, where the system is fully in control and human is intervening in very limited circumstances. The hypothesis here is that, stage 5 is not where you want to be. That's not the future that you're trying to define. And it's also highly unlikely that stage 4, where human beings have very limited role to play, is going to happen. So I think where we are striving for in healthcare, again, I'm trying to do the contrast between something that we are very familiar with, which is the driver experience, and in healthcare, where stage 3, where system is largely monitoring, but humans have a significant role to play, is where the holy grail, the desired state in the future, where humans also have a significant role to play in delivering care. And again, it's a debatable point. Many people have opinions on this, but again, I just want to sort of contrast the two worlds. So when it comes to healthcare, and again, you may be wondering, what are the areas where you can make a difference in the healthcare domain? There are quite a lot here. Diagnosis, really diagnosing conditions that human beings do today. Even if it's taking images and interpreting images that physicians do today. Interventions, what treatment do we want to give to a given patient? Patient monitoring and care. Does the patient always have to visit the doctor's office to be monitored and cared? Again, with the devices that are there and the algorithms that are in place, a lot of that could be done in the convenience of a patient's home. Access improvement, how do we improve access to healthcare? Virtual consultations with the doctor as opposed to going to a doctor's office. Augmenting patient healthcare providers. The physicians providing care, can they have an AI assistant that can help them in providing care? Drug discovery. Again, a big space. Clinical trials, disease prediction and prevention, and population health. And this is not an exhaustive list, but these are some important areas where, again, systems thinking, AI algorithms can really make a difference in healthcare. All of them are really right. Many of you are researchers working on some important problems. I would encourage this community really think strongly about healthcare questions that are in this class of problems, because there's a lot to be solved for and a lot of value to be created. So I won't get into all these areas. I'll primarily get into drug discovery and clinical trials, as well as disease prevention, and as well as population health. Given that my most recent role is in the pharmaceutical industry. If you have some time, we'll also cover diagnosis. And image-based diagnosis is one of the areas where machines are now routinely doing better than human beings. So, the algorithms are mature. There are a lot of success stories reported in image analytics where largely one can make the statement that machines are doing better. But again, that's not necessarily where we want to go. But again, in terms of the maturity, that's a fairly mature space. So let's talk about AI in pharma. So this is a picture that shows at a high level what happens in the pharmaceutical industry. In the pharmaceutical industry, you have some basic research, and then you get into the drug discovery phase, where you're considering a large number of molecules, perhaps hundreds of thousands of molecules as a starting point for a given target that you're trying to drug. And then, a lot of experimental work is done, a lot of lab-based work, some computational work, and then some of these molecules enter the preclinical phase. And long story short, it goes through various phases of clinical trials with increasing number of people, tens and hundreds and thousands, and eventually, if the program is lucky, one molecule will get approved by the regulators. Okay, so at a high level, this is the pipeline that happens in the pharma industry. And the metrics in that industry is it takes about 10 years to go from here to there, and it takes on an average $2.6 billion to take a medicine into the market. Okay, so massive numbers. And the other interesting number here is that when you look at phase 1 and when you look at what ends up here, less than 12% of the candidate molecules that enter phase 1 eventually gets commercialized. So for every successful molecule, there are many, many unsuccessful molecules that the industry is invested in, that eventually doesn't get anywhere. So think about this. The biggest challenge for the industry and also the opportunity for the industry is, can we get this 10 years and $2.6 billion into something shorter? Right? People are waiting for medications, and can we invest less, get the drugs into the market much faster? It's good for the patients, it's good for the industry. The other question is, why is it that 88% of the drugs that enter phase 1 fail? How can we, as a community, develop better methods and approaches where we can detect these failures earlier on, so that we are betting on the right molecules and investing on the right molecules? So, again, my strong belief is that the current way the industry operates results in these metrics. And there has to be something disruptive in the industry to change those metrics. Fundamentally different ways of thinking, fundamentally different ways of working in the industry. And my take again is that the advent of AI is fundamentally going to be a catalyst for that change. Because a lot of these processes, when you're working with different molecules, produces a lot of data. There is data that is generated from failures. And how can we meaningfully leverage this data, meaningfully leverage how we model human physiology, etc., to enhance the efficiency and effectiveness of this pipeline? And this is where the promise of AI really sits in the drug discovery and development phase. Because those metrics that we're seeing here, and this is average industry metrics overall, are dismal. I mean, these are, there's a lot of opportunity to become better. And that possibility will be provided by AI. And we're already starting to see some signs of that. And again, this, if you're interested, these are the various problems. I won't go into the details on all these. These are the various type of questions going from research and clinical development, manufacturing and supply chain, commercial, commercialization and other enabling functions in pharma, where there is significant activity in using AI to solve for the questions that are listed here. Again, tremendous set of opportunities in the pharma value chain across the board. So let me give you a couple of examples of what this means. And so when you look at drug discovery, at the highest level, drug discovery and development, the areas that are quite active now, one is in drug design. And again, when you think about this, even the starting point of the number of molecules that you want to consider, and which are the molecules, what kinds of molecules you want to consider. Again, the design aspect is an important one. There is again a lot of activity in clinical genomics. Clinical genomics, where you're really understanding genome variant classification, and also predicting genotype to phenotype activities. And again, with a tremendous amount of data that's being generated, the first human genome project ran into tens of millions of dollars. And now today we can get genome sequencing done in less than $1,000. And that's where the cost has decreased. And there is tremendous impetus to do genome sequencing, use that data to really understand many diseases and develop treatments for those diseases. And clinical trials is the other area. And when you think about that 10 years it takes to go from drug discovery to commercialization, a lot of the time is actually spent in running clinical trials, because you have to develop the evidence that it works in heterogeneous populations and do that in sequence. So, how do we accelerate our clinical trials in terms of design and operationalization of clinical trials? And again, we saw the need for that not too long ago when we had the epidemic, the COVID epidemic. How do we get these things into the market quite quickly? One of the recent exciting developments was in the space of protein structure prediction. Dr. Christian and Finson was a Nobel Prize winner in about exactly 50 years ago. He got a Nobel Prize in chemistry. And in his Nobel Prize lecture, he said, one day, scientists can predict the 3D structure of proteins based on the sequence of amino acids. So we all know proteins are a sequence of amino acids. But it is really difficult to determine the structure of proteins. Even though there are some really solid fundamentals, which are sequence of amino acids, it took years of lab work, meticulous work, expansive time-consuming work to determine the structure of proteins. But when you think about this has been Fermat's last theorem kind of problem in chemistry biology, sort of saying, hey, can we solve for this? If we can get the sequence of amino acids, can we output the structure of that protein? And it's very recently that you may have heard about this, where DeepMind, Google's DeepMind, developed an algorithm where they reliably could predict the structures of proteins. And this was considered to be a hard problem for a very long time. And it was AI methods that DeepMind used. The training set was very small. The training set that they had was only 170,000 proteins. And again, it's not an algorithm where you had a large training set to do this prediction, but that's where the advancements in AI methods are really powerful and giving us a lot of hope. Today, they have published the structures of 200 million proteins known to humankind. And there is a structured library that's available for everybody to search, for anybody who's doing work in this space. And they also open sourced their code. And I mean, this is tremendous. I mean, it's not proprietary anymore. And these are the kind of things that really advances science. In 2021, the Science magazine gave it the Breakthrough of the Year award because identifying protein structures and is a foundational building block for drug discovery, and something that people thought would be hard to do even 10, 20 years ago, and even today. There is the amount of lab work that goes. This fundamental change, advancement that is made by algorithms like AlphaFold 2 is giving a tremendous impetus to the use of AI in drug discovery. And there are more to come. This is just the beginning. The other aspect is about optimizing clinical trials. So once you discover a molecule that you have some evidence, you have modeled to have some potency on a certain target for a certain disease, you go through clinical trials, as I said. And how do you really reduce the time it takes for clinical trials? Right? There are certain things that you have to do. You got to test it on human beings for a certain amount of time. But when you really think about this, there are lots of other things that take up the time in executing clinical trials. That is, you have to identify the hospitals that the trials are running, the investigators, the protocols, who's included in the trial, who's not included in the trial, what are the patient characteristics, etc., etc. And in the industry, it was actually done, these decisions were really done based on maybe scientific intuition or experience. So if I'm running a trial in diabetes, I would go to an investigator who did my previous trial. So we asked the question, can we really make this a data-driven decision-making process? There's tremendous amount of data from our historical clinical trials. Can we take that and build some models to say, hey, for my next trial, how should I design that trial, and which countries and which hospitals should I run this so that I can run this to gain reliable results and run this in a minimum amount of time. So again, we took this as a work that was done at Lilly. We took a very analytical approach to solving this question, and glad to say that today every single trial that is done in our organization really relies on the output of this machine learning algorithm that we have built. When just 3 or 4 years ago, it was done completely in an experiential basis. So again, this is a different side of the pharma industry compared to the drug discovery area, but an area that offers tremendous potential and impact. When it comes to, again, clinical trials, there are lots of dimensions that one has to think about. Things like site health. Are we going to get quality data from any given site that we are running the clinical trials in? Primary and secondary endpoint selection. So what are those endpoint selections? Endpoints means what are the things that you are testing the drug for? When you're having a diabetes drug, for a simple example, your hemoglobin A1C is an endpoint because that's what you're measuring. Prediction of protocol amendments and so on and so forth. So again, a lot of dimensions that we are trying to optimize for when we are designing these trials. So let me switch gears a little bit and talk about care delivery. So we talked about the pharma space, about drug discovery and clinical trials. Now let's get into a little more around every one of us, what every one of us experience. Being in a care delivery setting, hospitals, doctors, and so on and so forth. And what are the questions, topics that are of importance and something that we can make a difference as a community? What is personalized treatments? We all experience this. We go to a doctor's office. They would look at us. They probably would have a diagnosis. 1,000 others would also go to the same doctor's office. They would have the same diagnosis, and we all get the same treatment. But we are all different. Every single one of us is made differently. Does the treatment paradigms today really leverage those differences to give the treatment that works for you as an individual? We are not there yet. It requires understanding of you as an individual, and it requires understanding of what will work for you. So the state of medicine today, largely, I'm not saying overall, largely is not personalized. It is based on population level understanding and population level interventions. So the opportunity that is there in front of us is personalized treatments. And it's happening in certain domains, it's coming in. Personalized treatments are not just going to be more effective for the person, but it also reduces waste in the healthcare system. How many times people take certain medications and that's not effective for them. So that's one area of importance. Surgical interventions, and again, robots are performing more surgeries than human beings as we speak today, and that's going to increase. And preventive care. Lot of healthcare systems around the world are designed to treat sickness. You're sick, you interface with the healthcare system, then you get treatment. But if you shift the paradigm to how do you prevent something from happening to your health, and that's the other, getting ahead of the curve. And again, you do that in pockets, but again, how do we do that systematically in healthcare in terms of preventive care? So those are some areas that are again emerging and areas that offer a lot of potential for research. Let me talk a little bit about the role of predictive models in population health with a couple of examples. This example is about the topic of readmissions. So what is a readmission? A readmission is when a patient is admitted in the hospital, and if that patient again comes back and gets admitted again in the hospital within 30 days of discharge, you call that a readmission. So the patient is coming back in 30 days. So either the patient was discharged before getting fully well, or the patient hasn't necessarily done the right things to be well after they got discharged, because that's why they're coming back. And in the US, there was a study that was done in the senior population, 65 plus, and the program that is called the Medicare program. And they found out that 1 in 5 patients are getting a readmission every time they get discharged from the hospital. So 20% of the people are coming back within 30 days. And then there were a few other things that were identified. Half of those patients now saw a doctor after they got discharged for follow-up care. And this is a paper from about 13 years ago, so data is from 15 years old, but it was kind of a seminal paper to understand this topic. And this cost was about 17.4 billion annually just for readmissions. And the 17 billion was about 0.1% of the US GDP at that time. So 0.1% of US GDP was spent in readmissions of seniors. And you sort of look at this question and say, hey, it's not just about the cost, but why are people coming back and getting admitted? What about the health we could be doing better to keep them healthy at home? Because nobody wants to come to the hospital and stay. They want to stay at home. They want to stay healthy. And then we ask the question, how can we identify the people who are going to get readmitted right from the time they're getting discharged from the hospital, right? So we can help with certain things. It may be in certain situations, even having food at their homes when they're coming back. If it is from a poorer sections of the society, they may not have food when they come back from the hospital. If you don't have food, basic needs, they may not have the medications, etc., etc. Really understanding what is causing those large numbers. And that's when I was working in a health insurance company at the time, and we look at these population health kind of questions and said, hey, maybe there's a role of analytics to really understand, if you ask the question, who is most likely to get readmitted once they get discharged from the hospital. So let's consider this simple example, just to sort of give you an idea about this. There's patient A and patient B here. Roughly patient A is older than patient B, and they have had some previous admissions. Patient B did not have previous admissions in the last 365 days. They had the same diagnosis. So let's say they're both getting discharged from the hospital with pneumonia, let's say. But many of the other factors are different. Patient A has many other comorbid conditions, other conditions that they have compared to patient B. But traditionally in clinical practice, the only thing that was looked at was the diagnosis. So there were some studies that were done saying, okay, people with who get admitted in the hospital with pneumonia have a higher readmission rate compared to people with other conditions. So that was actually probably not the right direction to go. There are many aspects of a person's health, and if you build a model that can really reliably predict the likelihood that somebody is going to get readmitted, that could be a way to manage and help people who have a high risk of readmission to reduce readmission rates. So again, this is work from more than a decade ago, but again, it is the construct and the approach that I want to share, and then and this was actually implemented in an industrial setting, which led to a significant reduction in readmission rates. So getting these scores. So let's say somebody with a score of 200, you would actually visit them at your home and make sure that they have everything that they need. Food, medications, actually follow-up appointments with their physician, etc., to keep them healthy. Because even from a financial perspective, spending on that is much lesser than spending on a readmission and admission when they come back to the hospital. So again, now in the healthcare ecosystem, many of these models are in place to really understand which of the patients at most risk. And I'll show you one more example in the diabetes space. And in diabetes is an epidemic. And again, as I said, about 30% of seniors are diabetic. If you look at it globally, when you look at the diabetes population, you can consider that as at-risk population, people who are pre-diabetic, who are at risk for diabetic, we call them pre-diabetic. People with low severity diabetes, and medium severity and high severity. So again, we can hold the discussion on what low severity, medium severity, and high severity means. And what happens annually is about 5% of people who are pre-diabetic will progress to a low severity bucket. About 30% of people in the low severity bucket will progress into medium, and then 3% into high severity. So how do we know which of those patients in the low severity bucket is going to progress into intermediate severity? Because they may need different sets of treatments to slow progression. Because some people progress faster naturally and some others don't. And that's where, in a clinical practice, if you don't use these tools, you will only be trying to catch up. Because after they progress to a medium severity condition, then you treat them. And that's where preventive methods are going to be important. And when you look at the metrics here, low severity people, this is a metric called admits per thousand. How many of them get admitted in the hospital per thousand every year? How many of them have foot wounds? How many of them have diabetic retinopathy? And how many of them have foot amputations? And so the advanced stages of diabetes, people get foot amputations. And as they progress from low to medium to high, you can see the numbers are increasing. On average, every person has 2.5 admissions per year when you're in the high severity, and foot wounds 30%, and 5% of them have to get amputations in the high severity bucket. So the point here is that if we can build analytical models to predict who's likely to move from these buckets to the higher level buckets, you can treat our diabetic patients in a more proactive way with different interventions. And that's again where some of the models that were developed looked at the data for each of the patients. And and for patients who are high risk to progress, there were different sets of interventions that were given. So again, a little bit more on the personalization side, but not completely there. But again, a good way to think about managing some of these conditions. Okay, let me skip ahead a little bit in the interest of time. And maybe I'll give you one example of diagnostics, because that's an area that I'm very excited about, given the huge progress that has been made. And in imaging, and different categories of diagnostics, imaging, digital biomarkers, even sound and voice diagnostics is used to now detect behavioral health conditions. Imaging, again, is very exciting, where AI algorithms are outperforming physicians routinely, and as I said a little earlier. And again, this is a paper, a graph from a paper by Eric Topol that was published in Nature, where they conducted some tests with human physicians, in this particular case, oncologists, and compared that with how machines and his algorithm did. So what you're seeing is that there are 135 images for carcinoma that was given to physicians, and each of the red dots are individual physicians, how they performed, and the green bar is the performance of an average physician. And this is melanoma, and you can see the green, average physician, and the blue curve is basically coming from the AI algorithm, and different types of images. What you can see here is the blue curve is outperforming the average physician in all cases, and this is not unique, as I said, and provides a good proof that machines can do much better than human beings now when it comes to imaging and diagnostics associated with imaging. And there's a really nice story that was published a little while ago, where a girl visited New York University Langone Health for a follow-up, and this patient had a certain kind of cancer and was treated for that particular kind of cancer. And that cancer was treated. The patient was good. And she came back again with similar concerns. And the physician actually diagnosed her again with the same condition, because the physician thought, hey, it is the cancer appearing again. But it turned out that the physician also thought, let's get some data, which is called methylation analysis check. And again, that gives indication. There is some study, some data that shows that methylation analysis gives different patterns of different types of cancer. And they decided to run this data through an AI algorithm, and they found out that it is a different kind of cancer that this patient had. Previously, the physician's gut feel with the biopsy and so on and so forth, imaging, was confirmation of the earlier cancer. So what would have happened if this was not detected with the AI algorithm? The patient would have gotten treated for the wrong kind of cancer, would not have gotten better in her condition, and she could have probably gotten worse. So again, the machines are now doing much better than what would anybody expect. So I'll share an excitement about one more topic before I wrap up, which is generative AI. And some of you may have seen a lot of buzz around generative AI. And generative AI is basically AI algorithms that can generate text, images, videos, etc., etc. And DALL-E, OpenAI's solution, where you should try it out. Get a free account if you haven't tried it out. Give it a statement, saying that Professor Karimi is sitting on the chair holding a mic. It'll give you a picture of him doing that, right? And that is the output. That's what AI algorithms can do. And last week, and it's very fresh off the press, OpenAI announced the arrival of ChatGPT. ChatGPT, you ask it certain questions, it will give you an answer. It's almost like students taking a test. And the amount of intelligence that it shows in the answers that it provides is just amazing. Again, get a free account and try it out. And why am I excited about this in healthcare? It is exciting because some of these generative AI methods can create protein structures because it is generating structures and or images that we are asking it to do. Again, this is not a picture of a dog. This is a picture of a dog that is created by DALL-E. It's the AI algorithm that created this picture. Okay. So to wrap it up, let me. So what is the role of AI as you start to think about this in healthcare? And as I said earlier, the complexity of modern medicine is so large today that no human being or no groups of human beings can know it all. There is a tremendous amount of knowledge that's being created. So how do we keep up? How do we really be at the cutting edge of these things? So the experts have to partner with the AI algorithm. It is the combination of the human and the machine that is powerful in the future. It's not just the human beings or not just the machines. It is a combination. And the human beings who know how to leverage the machine to do their work better will come out to be winners. So with that, I thank you very much for your attention and we'll be happy to take any questions.
Anyway, I'm sure you're all excited about all the success stories that Dr. Gopal has mentioned. We do not have much time, but I can take one or two questions.
Hi, Vivien. It's a very interesting talk. Thank you for giving us the nice picture for the future for these healthcare systems. One question is, out of these many items, which part the Eli Lilly mostly focus on? And the second question is, Yonsei University has very nice hospitals. The worldwide rankings of authorities. We have a lot of the research going on, and then what is the good cooperation models between academia and the hospital?
Yeah, absolutely. I mean, today I covered broadly the opportunities in healthcare, not just the pharma industry, human care delivery in the hospital systems and so on and so forth. For Lilly, Professor Moon, to your question, we are primarily focused in the drug discovery space, and again, that's why we are excited about the progress in areas like AlphaFold 2. Again, things like molecular property prediction, right? So quite often, why molecules fail along the way is that they don't meet certain property criteria, like solubility, etc. If we can have computational models that can predict those properties ahead of time, then we can really focus on those molecules that pass the test, right? How do we bring in computational methods? Even designing structures that chemists might not really think about based on their domain knowledge. So, quite often molecules are designed by chemists who have certain hypotheses. How about some structures that nobody has thought about, right? So drug discovery and then clinical trials. We also apply AI in the manufacturing space. How do we make our manufacturing operations much more efficient, and then in the commercial space, really understanding patients and getting the drug into the market. So we span the entire spectrum of the pharma value chain. And when it comes to academia, hospital systems collaboration, there are two things. One is we partner with hospital systems around the world in executing on our clinical trials. Right? So we can't execute on our clinical trials without the partnerships of hospitals and physicians. And the second is, of course, on various kinds of research, drug discovery research, clinical trial research. Now there's a lot of movement towards what we call decentralized clinical trials. So clinical trials historically were patients coming to doctors' offices and with visits and taking measurements and so on and so forth. But when you think about the digital devices that are available today, how can we reliably collect patient data on a more frequent basis with patients being at home, or patients not necessarily coming to the doctor's office. They can go to some other center that is more convenient for them, where some of this data could be collected. So, there is a big rethinking about clinical trials on how to execute clinical trials with the advent of digital devices and digital health. So, that's another area of very active research that's being done. Yeah.
Thank you. I think we have a few questions. Professor,
thank you very much for very stimulating talk. I'm Manu Kano, Kyoto University. Actually, I have been working in the area of medical service development and so on, and I sometimes faced the problem of limited number of data. And my question is that, yes, I'm interested in the generative AI producing artificial data.
Yeah.
And you said in the area of vision or images, there are many successful applications. So how about the sensor data, including time series data, or the data of healthcare record? So is there any successful example of generative AI?
Yeah. A great question, because a lot of the limitations for developing these solutions is lack of sufficient data. And there's an area of active work called synthetic data in the space where, again, it's an active area of research where we say, in the case of very rare conditions, it's hard to generate data with a small number of patients. So how do we generate synthetic data to enhance, in some sense, our training data set, which is, I can share some publications with you where some of that work has been done. But I would think that more needs to be done so that we're not missing out on certain dimensions, certain types of data when you're starting off from a small data set and then relying on that to generate synthetic data, right? So that's an open question and an area that's work needs to be done. Yeah.
Okay. If you can just make it quick. Okay, just one question.
Hello, my name is Hari and I'm from IIT Madras. So I have one question regarding this modeling for this readmission rate. If you see for our process models, most of these measurements are very objective. So for example, temperature is 320 Kelvin, it's 320 Kelvin, right? But when a patient you are trying to measure something, a doctor's experience comes in. So I may see that, okay, this is a severe case. The another may record it as moderate. So how practical these models are in terms of like how can you validate that is one, and the other part is of course like collecting data itself can be very expensive because all these measurements they are extremely costly. So if you maybe it might be cheaper to just treat a patient once he's having a disease rather than having to like collect data when he's healthy. So what's your
Yeah, again, good question. And we don't necessarily have to collect data for the purposes of modeling, right? The objective is to use the data that is collected with care, right? So let's say we have an electronic medical system. So all the blood work that is done while the patient is in the hospital, right? So it's not the subjective data, but it's all the actual data that is collected as part of care that is going into these models. So you're right. Some of the other ones, the examples that I showed are all numeric values. How many previous admissions does this patient have? What are the other conditions that this patient has, etc., etc. What were the hemoglobin A1C values if that patient is diabetic? So whatever data is collected during care, during the stay, is basically what goes into the model, and historic data for that particular patient that is available in the electronic health records. And you get fairly good accuracy with those.
Okay, I think let's thank Dr. Gopal for a very nice seminar and also a lot of interesting discussion. I'm sure we can talk with him later.